Welcome to the live webinar, the Neurological Examination with Nicolas Granger. My name is Joanna and I'll be the host for this webinar. Hopefully you can all hear me okay. If you're connected to audio via your computer, you may want to adjust the volume settings either on your computer, external speakers or headset, or select to use your telephone. To do this, click the Audio tab on your GoToWebinar control panel and select Telephone. Dial in using the number displayed in your webinar reminder. You will then need to enter your access code and the audio PIN, which is shown after joining the webinar. A quick word on your control panel. You can hide the control panel by clicking on the white arrow in the orange box positioned on the top right. During the webinar, you can ask questions by typing your questions in the white box towards the bottom of the control panel and then clicking Send. At the end of the webinar, I will ask Nicolas a selection of questions received. Due to numbers taking part in this webinar, you'll not be able to speak to either myself or Nicolas, so do use the questions facility. We'd love to hear from you. Our speaker for this evening is Nicolas, and I will now hand you over to him, and he will start with this evening's talk. Nicolas, the stage is yours, and it will be nice if you could say a few words about yourself before starting the webinar. Thank you.
Thank you, Joanna, and then good evening, everybody. So I'm going to talk about the neurological examination, and the main reason is that I practice as a veterinary surgeon in the UK as a neurologist. So I trained in Paris, so I'm French, did my residency training in Paris as well, and then moved to the UK in 2006, where I've been practicing as a neurologist since then, and in Cambridge and Bristol Vet School. I'm now working in a private practice in Bristol, in CVS. So that's the background. I hope you'll find the talk useful. I've been trying to make it practical and hopefully useful for your everyday consultation. There will be some videos during the talk that you'll be able to see. I can't speak through the videos with the system we're using, but Joanna will play them and I'll explain before and after the videos. So hopefully that will make things more practical and appealing for you. Right, so I think we're ready to go. I've got the screens working on my side, so hopefully you can see everything on your side, and you've got the slides as well. And I suppose the first question I tend to ask people when they do a neuro exam is why are we doing it? And it seems a trivial questions, but the first thing we need to know is whether the animal has got a neurological disease or not. And it's, as you know, you're often stuck at that point where you're not sure, is it a neuro disease or is it not a neuro disease? So it's quite useful to gain confidence that you're facing a neurological condition. And this is what the neurological exam is going to bring. The second part of the neurological exam, or second useful bits of information you're going to get from it, is you should be able to know where the lesion is localized. And you can do all this with your hands. Then to know what the lesion is, what the prognosis is, you need some background knowledge and a neurological test. I think you can see my arrow on the screen when I move it. So if you look at this sagittal reconstruction CT scan of the spine of a dog, you can see the bone in white, and you can see 2 sites of disc herniation there in the thoracolumbar region and 1 in the lumbosacral region. And so it will be difficult in a case like this to know which of these 2 lesions are relevant. Maybe one is relevant, one isn't. But by doing the neurological exam, hopefully you might be able to localize the problem to one of these 2 regions. And that's why doing the neuro exam is useful. By using advanced imaging, we're gaining more information about the dog's anatomy, but it doesn't mean that the lesions you're seeing are actually clinically significant. So the practical thing with the nervous system is that it's divided into segments. So it's very useful to remember that you've got brain divided into 4, brain cerebellum, brain stem, and then spinal cord is divided into segments as well, and we'll see how that can be exploited. And you got peripheral nerves and muscle. And each segment, each region of the nervous system has a specific function. So by looking at the signs, the neurological signs, you can attribute deficits to specific region of the nervous system and work your way from there. So the methodology of the neurological exam is basically it's kind of a tick box exercise where you go through a series of steps, just like a recipe, a cooking recipe, and you don't want to miss any step and do them in order, and hopefully that leads you to the answer. So we're going to go through taking the history, then you look at your animal or patient from a distance, then you're going to want to feel its body, do palpation, test postural reactions and reflexes, sensation, and then finally cranial nerves. Some people do the cranial nerves first. It's not essential, and you can do it in the end, look at the head in the end or at the beginning. But you'll see that one of the main crucial things I think is testing postural reactions before you do the spinal reflexes, and I think it's important to distinguish the postural reactions from the spinal reflexes, and hopefully you'll see why. So when you take the history, I'm not going to go through all the questions you might want to ask, but there's two crucial informations you want to have and secure when you're asking or talking to your clients. One is to know how the disease appeared, so the onset. Was it very fast or very slow? And then how it's progressing is the second information you need to know. So the progression of the disease over time. And with these two information, you will be able to select certain categories of disease that might be happening in the patient you're looking at. And that's very useful because you can rule out quite a number of differentials by just having these two information. So if you look at this graph where I've on the y-axis plotted the severity of the neuroscience and on the x-axis the time. If you think of a disease that is a vascular disease like a bleed or a stroke or a trauma or a toxic intoxication, the signs are usually going to happen very suddenly, reach a peak, and then they'll slowly get better. So either they die at that peak point due to the severity of the signs, or they slowly recover over time, and by time we mean weeks to months. If you think of a disease such as an inflammation, meningitis, or a cancer, the signs are usually slowly appearing over a few days, maybe a week or so, so they're not that acute, but they are definitely getting worse over time, fairly rapidly, to reach their maximum severity. So that's typical of inflammation and neoplasia. Sometimes remember that they might bleed when they have this sort of pathology, leading to a sudden deterioration. If you think of metabolic diseases, the dogs or the cat will have good days, bad days. So typically these cases wax and wane, but over time, over weeks, you'll see a gradual decline. Finally, disease called degenerative conditions, or often genetic conditions, are have a very slow progression, slow in onset over months, sometimes years. So you can see now that finally I put this A letter here for congenital anomalies that might take any different type of course, but you can see that by remembering the onset and progression, you can allocate your differential into one or the other category. Okay. So we said, so you take the history, and obviously that means gathering information about these two, onset and progression, but you want to ask also things about the dog's behavior, interaction with the owner, sleeping pattern, urinary fecal continence, and so on. But when the animal's with you, and once you've done this, you don't want to look at it from a distance. So typically you take the dog outside, or if you have a large consult room, look at it in the room, walking, ambulating in the room, and focus on looking at the head position, its position of the limbs. Has it got a wide base stance, a low head carriage, for example? Can you balance? Is there a head tilt? And sometimes it's useful to put them in their lateral recumbency to see if there's asymmetry appearing here or rigidity. Even abnormal postures like opistotonos can appear. So I'm bringing your attention here to a couple of definitions which I think are very useful to always keep in mind. especially when you're going to look at the gait. One is the definition of paresis or paralysis, which means an inability to trigger or perform movement. So paresis is a partial loss of movement, loss of voluntary movement. Paralysis is full loss of voluntary movement. So you might have para means back legs or hind limbs. So you can have paralysis means no movement in the hind limbs. Tetraparesis will mean no movement in all four limbs. And hemiparesis will be no movement in half of the body. And then with that, you often get ataxia, which is a pure sensory issue where there will be lack of balance or lack of coordination, leading to falls or falls mainly. So when you look at them from a distance or in the console room, you'd want also to check if there's circling or if there's head pressing, like this dog here, and look at their montation doing that. So then comes the more hands-on examination, where it remains important to do good physical examination by looking at the skin, the muscle mass, the joints, if you see any abnormal bony shapes, if they have joint pain. So orthopedic examination is also useful. And you might want to look for signs of abrasion, so dogs cuffing their nails, automutilation. I would often ask the owners whether the dog is automutilating or biting their paws. All that sort of information is useful, and you can gather it by also palpating, testing these joints. Don't forget about foot pads lesions. They can make them profoundly lame. Corns as well will make them lame, and sometimes mimic nerve root signature or neurological issues. So, I've been fairly brief, so we can move on to the post-reactions about the approach to your case. But hopefully, you've now got the case in the console. You've taken your history, had a look at it from a distance, and had a look at the dog or the cat in the waiting in the console room and see how it's behaving. And you might be starting to get a feel for the presence or the absence of a neurological disease. But what is going to reveal neurological condition really is the testing of the posterior reactions. So that comes first, and it should be very clear that you do your posterior reactions first, and then your spinal reflexes. So when you do this, you see this dog with the paw turned, and the dorsal surface of the paw is touching the ground. So it's obviously in a very abnormal position, abnormal posture for this dog. And you can try and think of the anatomical structures that are involved in putting this paw back into normal position. So when you put this paw in this position, what's happening and what's happening to correct that abnormal position. And so if we think about it, then you've by moving the paw that way, you've been stimulating the joint proprioceptors. They feed onto the sensory nerves that are sending along the leg, branch to the that is connected to the dorsal ganglion, which branch to the neurons, sensory neurons within the spinal cord, ascending through the spinal tracts. It relays through the cerebellum, the brainstem, and projects onto the sensory cortex, where the animal is now aware of that abnormal position. In response, the sensory cortex will feed information back to the motor cortex, or voluntary movement control center, and you get a descending motor information going through the cerebellum, through the spinal cord pathways, branching to lower motor neuron, through a motor peripheral nerve, neuromuscular junction, and your effector, the muscle. So you can see that by just a simple test, changing the position of the paw, you've involved all these anatomical structures. And therefore, you can understand that testing this movement is not specific for one of them. It just, if it's abnormal, it just tells you that there is something unusual along one of these structures, but it doesn't tell you which one. Okay, so when you do your posture actions, what you're doing is basically challenging the animal, putting its limbs and its body into unusual postures in order to assess the response. Is the animal able to produce an appropriate movement in response to the change? And is this movement in response well coordinated? How does it happen? Is it too fast, too slow, too wide, and so on? And when you test posture reactions, you're testing both motor and sensory pathways, as I've showed you. So there are a range of them. I'm going to show them one at a time. And it's good practice to do all of them. And if they're all normal, you can be confident that you haven't got neurological issues or disruption of these anatomical pathways. Now, the animal could be normal in your examination on one occasion and abnormal the following day, but you just have to repeat a new exam in that case. And for cases with epilepsy, for example, you might have find a normal neurological exam, but the good practice is to do all of these tests. If you have done some of them and they're obviously wrong, you don't necessarily need to do all the tests. It's like if you have a paralyzed dog, you know that it's not going to use his legs whatever test you do, so doing the posture reaction is slightly meaningless. But if they are normal, you continue to do them one at a time. So first of all is proprioceptive testing, which we've seen, which I've explained a little bit in the previous slide, but it's called the knuckling test. It's a conscious test, so it involves proprioception, and here is another definition for you. Proprioception is your awareness of body position in space. So if you all close your eyes now, and ask you to touch your nose with your finger, you can do that very well. Okay, so you've all done it now, and you realize that you don't need to see your hand to be able to do that movement and be very precise at it. So that's proprioception. You're aware of your body position in space. And when you do the knuckling test, it's a conscious test. So the dog is aware of the limb movement. And therefore, if it's distracted or has received an injection of sedation, he might not perform very well with the test because his consciousness is involved and distracted. There's another way of looking at conscious proprioception is to the paper slide test. When you put the limb on a piece of paper and pull it aside, that is testing more the proximal joints, proprioceptors, whereas the knuckling is testing more the distal joints. So another postural conscious postural action is the visual and tactile placing. You'll see these in the video we're going to play in a minute. And you basically bring the legs of the dog towards an obstacle, and when the limb is going to touch the obstacle, there'll be a movement to place the limb on the table. So often it's the examination table. And the visual placing is before the limb is touching the obstacle, you see the animal will see the obstacle and reach for it. So these involve consciousness as well. They might not perform them very well. And this is why they're often seen as very subjective tests, and repeating them is useful. And then you can move on to unconscious test. So I've written it here, unconscious test. These are called hopping tests, where you're now going to put the animal in a difficult posture and put its weight on one leg, for example, like here for the hopping test on one limb, and try and see if the animal is able to correct and maintain his balance and posture during a difficult movement. So if you think of the center of mass or center of gravity of this dog as this red asterisk here, draw a line vertical to its leg, and you're going to push the animal. So all the weight is on that forelimb. You're going to push the animal to the right. As the center of mass is going to go past that line, the animal will have to hop. So there'll be a hopping test, a hopping movement in response. If this doesn't happen, it will fall. And so really what you're looking at with this test is whether the animal is able to hop and balance or whether it's going to fall, which would indicate then a deficit. You can repeat that with 2 legs at a time, that's called hemi-hopping, or 2 back legs, 2 front limbs, that's called wheelbarrow, or wheelbarrow on the hind or wheelbarrow on the front. Some people will grab the pet, lift it in the air and let it drop on the floor to see if there's a bouncing reflex on the hind limbs, which is called the righting reflex. That can be quite useful as well. So I think we've got a question here. First question, I was asked to put through the talk 2 main questions for you to keep your interest. And I was probably going to read that one while I think Joanna is starting the poll, and you can vote, I think, on your side. But I was basically here asking you how long do you perceive a neurological exam? Yeah, the poll is open now. So how long do you think a neurological exam routinely take? And I've given you 4 different options: 5, 10, 20, or 30 minutes.
Okay, I give you a few seconds to select your answer. Okay, so we have 40% answer 30 minutes, then another 40% answer 10 minutes, and 20% selected 20 minutes.
Okay, so there's quite a good variety of answers. So I put that question because I was looking into publication who might have looked into it. And I couldn't find very much really. There's a paper in Veterinary Records a long time ago suggesting that 10 minutes is about the time that you should take for a trained vet. So I think 5 minutes, you're all right, that 5 minutes is probably too quick, but I think people often perceive the new exam to be something quite difficult to do and time consuming, and 30 minutes for me would be quite a long time. I think we're probably more between the 10 and 20 minutes range. And I think usually you do a lot of your neurological examination as part of your clinical examination in the consult room, because you look at the head, you can immediately see if the dog can see, hear. So it's quite a lot of information you're gaining by your clinical exam without really considering or imagining in your head you've done a neuro exam. I think 10 minutes is, once you get used to this series of tests, is probably about right. That involves just doing the neuro exam, not necessarily building your differential and having to think about the possible options. So that's what I would say for that question. So moving on to the next part, hopefully. You've seen all the postural reactions, and as I said at the beginning of this series of tests, what they will tell you is whether there is an anomaly along the neurological pathways or not. And so at that stage, if you have abnormal postural reactions, then you know there is a neurological disease somewhere, and you want to localize it more precisely, but you don't know which segment is involved at that stage. And the way to know which segment is involved is to perform the spinal reflexes, which is why you do them as a second series of tests. And the spinal reflexes are segmental. So the concept is that if you see a normal reflex, then the nerves responsible for that reflex are intact. If you see a reduced reflex, then the nerves are affected, or the segment controlling these nerves is affected. And so it's a work by process of elimination. So it's going to go through the different reflexes, and on this slide you can see the different segments called C1, C5, and T3R3. These are called the upper motor neuron segments, in the sense that they haven't got any nerve directly controlling the legs, whereas the C62 segments and the 4, 6, L4, L6, L6S1 segments control directly the limbs through their spinal nerves, musculocutaneous, axillary, radial, median, and ulnar for the front, and femoral and sciatic for the hind limbs. So bear this in mind, this schematic. And I've listed here in that table all the nerves and where they're coming from. You don't need to remember this by heart. It's just so you have it in your notes. And I'll go through each of the reflexes one by one. So I'm going to skip through these quickly, and then you'll see in the video how they function. So because I couldn't play, I was allowed 5 videos for that talk, so they're all grouped in one video instead of playing one at a time. But you will test the radial nerve here by tapping the tendon of the triceps at the elbow, and you're looking for an extension. So the one nerve doing extension in the forelimb is the radial nerve. Only one nerve doing extension. So tap the triceps tendon and you see an extension of the elbow. We can also do the extensor carpi radialis, which is this muscle there, dorsal to the forearm, and you'll see an extension of the paw as you do that. Then the biceps reflex is not a very reliable test. You'll see that I put it in the less reliable as the radial nerve as well. So we don't tend to perform it very routinely and leave it. You'll see the reason why in a minute. The musculocutaneous is innervating the biceps, and when you tap the tendon of the biceps, you get a flexion of the elbow. But animals being quite stressed, usually their legs are already flexed, and so it's a difficult reflex to see. However, you can do the withdrawal, which is a much more reliable and easier test to do when you pinch the toes with your fingers first. So you don't want to cause pain, but just apply some friction on the skin there, and you will then see a withdrawal response with flexion of the limbs, and that involves all the nerves listed here. So you see that the musculocutaneous is there, so you're testing it by doing that reflex. So just that simple withdrawal test most of the nerves in the forearm. The only one you're not testing is the radial nerve, which is extensor and a bit more tricky to see. Back legs, you have the femoral patellar reflex. It's a very reliable reflex. You tap the tendon of the patellar tendon, and you see an extension of the limb. It's originating from segments 4 to 6, and then you have the sciatic nerve. So you can test tibial cranial muscle by hitting the tibial cranial where my thumb is there, and you see a flexion of the hock. Or you can do the gastrocnemius tendon test, giving an extension of the hock. If these are difficult and they are not all that reliable, you have the withdrawal reflex here, just as for the forelimbs, where you pinch the toes and observe a flexion, and you're testing both components, peroneal and tibial. So that's quite a useful one to do. So in summary, the 3 main reflexes you're going to use are the withdrawal in the back, withdrawal in the front, and patellar reflex. And that gives you a pretty good idea of how these segments, lumbar and brachial, are working. Peroneal reflexes, pinch the margin of the anal sphincter and see a contraction. And then I'll give the microphone to Joanna to play the first video.
Thanks, Nicola. Just a second. Back to you, Nicola.
Okay, great. I think we're back on the, so you can hear me again, hopefully. So yeah, you've seen in this video a few examples of the hopping reactions, and you'll notice that when I was doing them, I was trying to put the weight of the animal on the leg we were testing. So for the hopping test, you try and lift all the weight and put it on one leg, or the wheelbarrow. So the principle is to put the weight on the leg you're testing, see if the dog will fall. You see that I lifted the neck as well to suppress vision when I was doing wheelbarrow in the front. And hopefully you had a view of the spinal reflexes. You can see that some, like the biceps or the gastrocnemius, you don't see a good response. So these are tests I don't perform routinely, but the withdrawal are very reliable, as well as the patella. Okay, couple of other reflexes you do. The paniculus reflex, as you know, you pinch the skin with a pair of mosquito forceps, just cranial to the ilium wing, which corresponds usually to dermatomes 4 to 5. And this is indicative of lesions 2 to 3 segments above. So really the paniculus reflex test lesion in the T3, L3 spinal cord segments. When you pinch around L5, you're testing L3. And so lesions below L3 spinal cord segments rarely cause paniculus cutoff. But you pinch the skin, get a twitch. If there's no twitch, you carry on testing along the trunk up until the point you see a reappearance of the reflex, and that indicates the level of the lesion, 1 to 2 segments or 2 to 3 segments, depending on what you read, above the cutoff. Cutoff is not indicative of a prognosis. It just helps you to localize the lesion. And there's another reflex I wanted to mention, which is called the cross-extensor reflex. And sometimes you have heard that or seen that if you flex one limb when you do the withdrawal, the other leg goes rigid and extended. And the reason for that is if you go back to the normal situation, when you're bearing weight, so the dog's bearing weight on its legs, there's a balance between the flexor and the extensors. And when there is flexors in response to that, there's an extension to keep the balance. When the animal is lying on its side and there's no pressure on the feet, this reflex is abolished. But if there is a lesion above the lumbar intumescence, so in the thoracolumbar region, for example, that natural reflex tends to reappear in the lateral recumbency, and you see an extension in response to a flexion, which is normally not happening. So that's a sign of an upper motor neuron lesion. It doesn't give you a prognostic, any prognostic value, but helps you to gain confidence that this is an upper motor neuron lesion. So you can test sensation. The main one is testing deep pain, and the pathways for pain are located deep into the spinal cord, so it's important to test that thoroughly. It disappears when the animals are paralyzed, so you have lots of deficits happening before you lose pain sensation. So animals that are walking or have voluntary movement, they will have pain sensation, so there's no need to test that. But in those with complete paralysis, you want to know if they have deep pain. And the reason it's important, because if deep pain has disappeared, you can assume that the deepest part of the spinal cord have been damaged. When you test pain sensation, deep pain, you pinch the toe, you're going to see a withdrawal reflex if the lumbar cord is intact. So the withdrawal is the reflex, but it doesn't mean that the animal has perceived the stimulation, and you're going to get an information going up to the brain and the animal's turning towards you to show that you could feel the stimulation. So you get a behavior response, and that's really what you're looking for to ascertain that the animal has sensation. So it's important to test, and that has a prognostic value, because animals with spinal cord lesions and no pain sensation have a much lower chance of recovery. Okay, so the dermatomes, I'm not going to go through them. I've just listed them here, so you've got them in your notes, and you can refer to that. We don't learn these by heart and just then go to a book when you want to test them. So you've got front limbs and back limbs here all listed. But what I wanted to focus on now is, now you've seen the posterior actions, the spinal reflexes, is show you how you can put that into context and localize to one of the segments of the spine. So you've got the upper motor neuron segments, where there's no common centers and the lower motor neurons where segments where you have motor neurons and spinal nerves controlling the leg movement directly. So with the upper motor neuron, you get more of a spastic gait. The reflexes are normal. The muscle atrophy is usually mild, just disuse, and the loss of sensation involves the whole body behind the lesion. With a low motor neuron, you tend to get more of a flaccid tone, reduced reflexes. The muscle atrophy is very rapid within a week due to the trophic role of the nerves on the muscle, and you get localized loss of sensation to certain dermatomes depending which low motor neuron or nerve is involved. So perhaps we can have the video too, so you can see 3 cases, and I'm going to explain them one after the other. Thanks, Joanna.
Thank you. Just a second. Just a second. I'm just trying to play it. I'm just not being able to show this one. I'll just try it again. Sorry about that. I'll just try again. Sorry, Nicola, I just haven't been able to play this one.
Can I see it if I play it on my screen?
Yeah, if you could try, that would be good. Thank you.
So that hopefully, if you're seeing my screen, I can see the video. So can you see that?
Yes, I can see it.
So hopefully everybody can see the video. Maybe people can comment on the chat box if they do see it.
I can see it.
Okay.
You can comment if you want.
Okay. Yeah. So do you think people can see it?
I believe so.
Okay. So well, we're going to go through these 3 cases anyway in a sec, but then I'll just leave this one. Go. I'll just leave the video run. I'll comment it again.
Thank you, Nicola.
Okay, so what I'll do is I'll explain the videos and then we can play it again maybe. Oh yeah, people say yeah, I can see it. So yeah, so if you think of the last case where you've seen the Samoyed, he can walk, but the gait is very disturbed, but it is bearing weight, and that's typical of cases with lumbar or lumbosacral lesion. They rarely go paralyzed. They can't go paralyzed because they still have femoral function, femoral nerve function. So you can see that on this last Samoyed case, the femoral patellar reflex is working well. It's actually increased because there's no flexor tone to counteract the extension, but the withdrawal is very reduced, so you can't withdraw the leg, and that's typical for sciatic nerve lesions. If you notice in the video, it's got quite a flaccid tail. Whereas the German Shepherd has very good withdrawal. You can see that when we were pinching the toes, he was flexed very well, and he had a good patellar reflex as well. Nevertheless, he's very ataxic and wobbly, but that's typical of a tissue artery lesion when the spinal reflexes are all intact. Whereas the Doberman had this very frog-like walk, where he was becoming to lose the ability to bear weight, and that's because the femoral segment or spinal cord segments controlling the femoral nerve are starting to be involved, and you can see that his patellar response was very reduced, as was his patellar reflex and the withdrawal were becoming reduced. So it just shows you the range of or the progression of deficit from just sciatic to femoral, then tissue artery lesions. And so with all of these three cases, you can see that they're using their front limbs well, but obviously their gait is abnormal in the back legs. If the lesion is on the lower motor neuron, so in the intumescence here, you're going to have reduced reflexes in the pelvic limbs, but obviously the front limbs have normal reflexes. So you've got posterior action deficit in the hind and reduced reflexes. If the lesion is now affecting the tissue artery segment, you'll still have posterior action deficits because the brain doesn't control the back legs well. There's a blockage in the upper motor neuron segments, but the reflexes are normal. Sometimes people call them increased, but it doesn't help to localize any further. And they have normal front limbs function. So perhaps I can just play that video quickly again.
Okay, we'll try again.
I'll play it here on my side. It's fine.
Oh, okay.
People can see it. Then you've got the German Shepherd, who's showing an ataxic gait. You can see that it's difficult to turn here. The proprioception is involved. So it's got a neurological condition, but it's got a very good withdrawal here. So you don't hardly need to touch the leg to see a withdrawal, and here as well. So that's typical for a tissue artery lesion. Yeah, the patellar reflex doesn't show up somehow here, but it had normal reflex. If you move on to the Doberman here, you can see that it's hardly ambulatory, and he's got this very frog leg appearance, frog gait. And that's because he's lacking quadriceps tone, so he's lacking femoral patellar reflex. And he's got a withdrawal, so his sciatic function is it's got some sciatic function, but not fully on this other leg, and he's lacking patellar reflex. So that's why he's starting to lose the ability to bear weight. And the Samoyed case that comes next, there is bearing weight, but it's very palmy grade. He's got difficulties hopping, and he's got a good patellar reflex, but no withdrawal at all. So that's typical for sciatic nerve or lumbosacral segment lesion. Okay, so I'll go back to the talk, and I think there's another question here, another poll for you, where I'm playing a video and then ask you what is the Babinski reflex. So do you want to try and play the video, Joanna?
I will.
Okay, right, thank you.
Okay. I'll try now. Okay, it's coming.
Okay, so I think you can vote for one of these answers. You've seen that test on this dog, Plantosaur. So what is the Babinski reflex? It doesn't exist in dogs. It's a sign of forebrain dysfunction. It suggests the presence of an upper motor neuron lesion along the brain or spinal cord, and this is a normal reflex present in dogs.
All right, I'll just give you a few seconds to select your answer. We need a few more people voting, please. A few more seconds. Okay, so 50% answered this is a normal reflex in dogs. 25 selected it does not exist in dogs, and 25% an upper motor neuron lesion along the brain or spinal cord.
Okay, great. Yeah, it's to keep your interest, and for those who are keen neurologists, it's a typical reflex performed in people. We don't really know whether it exists in dogs or not, but in some cases, like you've seen on the video, you do seem to get a response, and it's when you brush the plantosaur, you get an extension of the hook, and the digit goes up or going up. So it does seem to occur every so often in dogs. It's a reflex that is absent in the normal individual, the normal human. You shouldn't see it. When you see that extension happening, it means that there is disinhibition. So the brain or spinal cord centers are not able to control and turn down that reflex. So it is a sign of an upper motor neuron lesion in the brain or spinal cord. It's one of the triage signs that's used in humans in the trauma room. In dogs, we don't know if it does exist, but in some cases, like you've seen on this video, I think it does. So that's quite an interesting one to mention. So we've got this video of 4 cases with cervical lesions now to localize the problem to C1, C5, or C62. Do you want to play this video, Joanna?
Yes, I will.
Great, thank you.
Just a second. I'm just opening it now.
Okay. Okay, great. So you've seen a couple of cases here. And for the first example of this golden retriever, you can see that the dog is very flaccid, first of all. So that's one of the example where you see that performing your posterior action is not useful. It's obviously has a neurological condition. But then these are the spinal reflexes here that are important. And you can see that the back legs had normal reflexes, whereas the withdrawal in the front was quite reduced. So that's evidence of a C62 spinal cord segment lesion. And for the second case, you could see the gait anomaly. As the dog's moving towards the camera, you can see that it's very ataxic, paretic. There's a knuckling deficit there, but the reflexes were very good in the forelimbs. So you see a good triceps response, which is quite uncommon to get. So when you see it, it tends to suggest an upper motor neuron lesion. And you can also see very good withdrawal in the front and the back, as well as patellar reflex. So in this border collie, all the reflexes are okay, and that points towards a C1, C5 lesion. So if we go back to this schematic of spinal cord segments with the upper motor neuron and lower motor neuron lesion in a dog with tetraparesis, so problem is the fore and the hind limbs. So the posterior actions are abnormal in fore and hind. You expect with a lesion of the C62 segment to have reduced reflex in the front limbs, but normal reflex in the hind limbs. These neurons, the lower motor neurons of the lumbar intumescence, are intact. But if the lesion is now affecting the C1, C5, some people say C1, C6, or the brain, you're going to get normal reflex in the front, normal in the back. So we can understand that these groups of lower motor neuron here are intact. The only situation where you have reduced reflex in the front and the back is with neuromuscular disease, when the peripheral nerves outside brain or spinal cord are involved. So I hope that all this makes sense, and then with that information, you can now localize problems along the spinal cord. I was going to use the last 5 minutes to talk about cranial nerves briefly, and just go through them just as a refresher. And there are 12 cranial nerves. One is the olfaction, and just reminding you that you try and use food to test olfaction rather than irritant substances like alcohol, which stimulates the pain pathways in the nasal cavity and brain. So it's the trigeminal nerve. So use the food to test olfaction. Don't ignore it. It's often it can be affected with olfactory bulb lesions. And then you go on to vision by either looking at the animal ambulating in the house and sorry, in the room, or testing it with an obstacle course or a cotton ball. You can also perform the menace response, where you hold usually hold the muzzle of the nose of the dog and mask one eye. So here's the right, and we're testing the left, and bring the hand closer to the eye in a brisk movement, not too close, so you don't move the air towards the eye, which will cause a blink. So try and stay a bit away, make sure that the dog is looking, get the dog's attention, and you should see a blink response, which involves facial nerve. So you get vision, cranial nerves 2, optic nerve, and then a facial nerve response. As you do that, you also get a turn, so the animals tend to go away from the menace. Vision goes through the optic nerve. Here's the retina, optic nerve, optic chiasma, and project onto the occipital cortex, and that's when the animal can see and is aware of the stimulation. When you put the light onto the eye, what will happen is a stimulation of the parasympathetic fibers of cranial nerve 3, leading to constriction of the pupil on the same side. As you do that, you've got a consensual response through the same parasympathetic branch, but decussating to the other side, causing a consensus constriction of the pupil on the other side. So you test the direct and consensual responses, and you can see that if your vision loss is due to a cortical lesion here, your PLRs are intact. But if the vision loss is caused by, say, an optic nerve lesion or a lesion near the optic chiasma or pituitary gland, then you might have reduction in your PLRs. So people tend to define pre-chiasmatic or post-chiasmatic loss of vision, depending on the presence or absence of PLRs. Cranial nerve 3, 4, and 6 are the oculomotor, trochlear, and abducens nerves, and they innervate here different groups of muscles around the eye, which I've listed here. Again, not necessarily need to remember them by heart, but just so you've got them in your notes. The important thing is, if you remember this, that a lesion of the oculomotor nerve leads to a ventrolateral strabismus here. That's the most common by far. A lesion of the abducens leads to a medial strabismus here, and the lesion of the trochlear muscle nerve leads to a dorsolateral, so strabismus, so this direction. These are the broad directions you get. The oculomotor nerves 3, 4, and 6 are obviously used during the physiological nystagmus. So when you move the head from right to left, you have a slow phase away from where you're moving the head, and then a fast correcting phase. So when you move the head, you're stimulating the vestibular system, the balance system, and in response to that, you get an eye movement. So the oculomotor nerves are involved as an effector, but your sensory nerve is the vestibulocochlear nerve. You do that in a dorsiflexion or lateral, right to left flexion. Testing sensation on the face is done by touching the contest lateral medial of the eye to test the mandibular branch of the trigeminal nerve or the maxillary branch. And you can also test the corneal reflex by gently touching the surface of the cornea with a cotton bud or the tip of a swab, something atraumatic, and you elicit a blink. That's the ophthalmic branch. Remember that a dry eye or dry nose means you've got involvement of the facial nerve responsible for lacrimation and production of nasal secretions. So here's an example of a dog with a dry nose on the left and Horner syndrome here. Jaw tone that is seen as a drop jaw when it's absent. You can open the mouth of the dog and appreciate the tone. It's often something you do when you're testing the gag reflex. If you get a lesion of the motor branch of the trigeminal nerve, you'll get quite severe muscle atrophy of the head on one side. So that's masseter and temporal muscle atrophy with an ophthalmia on the affected side. So the eyeball tends to sink back into its orbit due to the lack of musculature behind it. Facial movements are controlled by the facial nerve. So you get an open palpebral, a reduced palpebral fissure, facial asymmetry with a drop lip, drop ear, drooling as well. The others will have noticed that. And remember that the facial nerve does the sensation of the first 2/3 of the tongue and the palate, and does lacrimal glands, as we mentioned a minute ago. You can test that with the Schirmertian test. In chronic cases, you get a deviation of the face away from the abnormal side due to opposing tension on the normal side. Vestibular nerve, we've talked about it a little bit. You get a head tilt when there's vestibular dysfunction towards the side of the lesion, and deafness also is possible. When it's unilateral, you might not hear it. With that, you get nystagmus. And the way to remember nystagmus is that if the head is tilted to the right, say to the right, then the eyeballs are going to drift slowly to the right. So the balance, the horizon is now tilted to the right. So your eyes, or the affected eyes, are going to drift slowly to the right. And there's a point where they can't rotate anymore because they're held by muscles, extraocular muscles. So when the extraocular muscles reach their maximum tension, at the end of the slow phase, rotating phase, there's a stretch reflex that puts the eye back into its orbit. So there's a fast correcting phase, there's a brisk muscle twitch that brings the eye back into its normal position. That's the fast phase, which is therefore away from the lesion. So if the head is tilted to the right, you get a slow drifting phase to the right and a fast correcting phase to the left. And then again, slow drifting phase to the right, fast correcting phase to the left. And that's why you get a slow phase and a fast phase with your nystagmus. And the slow phase indicate the side of the lesion. And the gag reflex, we talked a little bit about it. You put your fingers down the throat. If you elicit a gag, you can massage the pharynx as well if you don't want to risk your fingers. And you will test also sensation of the tongue, larynx, pharynx by doing this. So with cranial nerve 9 and 10, you get megaesophagus dysphagia, laryngeal paralysis, changes in the bark with affection of nerves 9 and 10. Nerve 11 is difficult to test. If you do advanced imaging of the head or neck, you might see the atrophy of these muscles, but otherwise it's not so easy. And then 12 is tongue movement with an asymmetry that will appear, and the tongue is deviated to the opposite side of the atrophy. I put here in this last video a few examples of anomalies. We haven't got time to go through all of the changes with the cranial deficits, but are you able to play this last one, Joanna, please?
Yeah, well.
Thanks very much.
Okay. All right, just opening.
Okay, so it was just a couple of examples here of maybe tests that you don't commonly do for your cranial examination. So the corneal sensation, you could clearly see in this cat the normal and abnormal response. Also testing the nose sensation, so trigeminal nerve, and then the rabbit is quite a good example, I think, of how the vestibular system dysfunction triggers nystagmus, and you can see clearly this slow phase to the right, this fast correcting phase, and slow phase to the right, which is the side of the head tilt. So I think it's quite nice to understand how it works with this video. Yeah, I put a couple of slides maybe just as a conclusion on the cranial nerves, because it's often useful for you to try and differentiate a central versus a peripheral vestibular syndrome. It's something that is quite important. If you think of the structures involved in the around the central vestibular system in the brainstem, you've got all the cranial nerves we talked about are located in there. So if you have a central lesion, central vestibular lesion with a head tilt on one side, you tend to have lots of other cranial nerves involved, and the conscious is affected, the motor pathways are involved as well, so you get knuckling deficits and motor deficits with central lesions, whereas if you have a peripheral lesion, so if the lesion is located in the peripheral vestibular system, you don't get the cranial nerve deficits, you don't get the motor deficits, you don't get impaired consciousness, and it's a pure sensory problem with a balance issue. So the dog might have a head tilt, lose its balance, but it can move, is conscious, and has no other cranial deficits except those facial nerve and sympathetic system that are running close to the inner ear, inner ear. So I hope that was useful, refresher for you on the neuro exam, and I'll be happy to answer this question. Thank you.
Thank you, Nicola. I have one question you may already have answered, but I'll read it out to you. Why is it important to test postural reactions before testing spinal reflexes?
So yeah, the spinal reflexes are giving you information about a specific nerve and about a specific spinal cord segment. So they're really indicating dysfunction in one small part of the nervous system, whereas the postural reactions are testing the whole of the nervous system and the neuromuscular system. So the principle is you test the whole of the nervous system first. So you look at all the postural reactions and try and detect an anomaly. And if there is one anomaly, then you refine your localization by doing spinal reflexes that are testing much more narrow regions of the nervous system. So you refine it by the reflexes. So as a rule, you do postural reaction first, then spinal reflexes.
Okay, thank you so much. I will now conclude our webinar. Big thank you, Nicola, for delivering this evening's webinar. It was very interesting. For the attendees, we have a test site that you can visit online. You'll be emailed the access details in exactly 1 hour to your Green Cross email address. Should you not receive this email, please log into your VET webinar account using your email over the account tab in the top right of your screen and select My Webinars. Your quiz will be located here along with the handouts from tonight's webinar if you have not downloaded them already. And also the edited version of this webinar will be available in that site within the next week. Please ensure that you have completed all the fields marked with an asterisk prior to completing the quiz to ensure that your certificate is printed correctly and registered against your CE register. Thank you for taking the time to register on this talk, and should you have any questions, please feel free to contact us. Good night. Thank you.